So what about the treatment? The treatment of lung cancer, we have two parts: the treatment of the cancer and symptomatic treatment, what we call comfort treatment. We have to treat pain, the associated signs, and the bronchial obstruction if it exists. First, the treatment of the bronchopulmonary cancer. The methods are surgery, which is the only curative treatment with the only patients who are having a hope of curing, but we have problems by selecting these patients. Is it the tumor, is it resectable, and the patient, is it operable? It's an oncological surgery. We do lobectomy or even pneumonectomy, and with always lymph node dissections. In some cases, we have to do an extended excisions if we have the involvement of the chest wall or of the carina or the supravena cave. The second method is what we call radiotherapy. We have to give a dose of 45 to 60 gray by session of 2 gray per day for 5 days a week for 6 weeks. And we have new modalities, what we call hyperfractionated radiotherapy, and this is with small degrees of radiotherapy, conformal radiotherapy with 3 dimensions, or what we call stereotaxic radiotherapy. It could be done alone or with chemotherapy for inoperable patients who are not metastatic. And sometimes we can do it in pre or post, before the surgery or after surgery. And in the advanced stage for some metastasis like brain metastasis, we could do radiotherapy in the brain. And we have also recently what we call endobronchial chemotherapy. We do radiotherapy in endobronchial. The third method is chemotherapy, and it is indicated in advanced and locally advanced metastatic forms. We can do it exclusively or associated to radiotherapy or sometimes before surgery, and it is exclusive for small cell carcinomas. Other methods is what we call targeted therapy for patients who are having that oncogenic mutation like EGFR, ELK, and ROS1, and immunotherapy for ones who are having PD-L1. What about the indication? What you have to know is that the therapeutic decisions are always taken during a multidisciplinary consultation meeting. So no one is taking the indication of treatment by himself. And globally, we have 3 big stages. We have what we call located tumors or locoregional tumors or metastatic tumor. For located tumor, it's surgery. For locoregional tumor, we can begin with chemotherapy, then surgery. And for inoperable patients, we do chemoradiotherapy. And for metastatic tumor, it is exclusively chemotherapy. What about symptomatic treatment? It is as important as the tumor treatment, and we have to consider it whatever stage of the disease and the patient's conditions. And it contains several components. First, the treatment of the pain, and we have steps of treatment, 3 levels. The first one, we begin with peripheral analgesics like paracetamol, and if it doesn't work, we go to the level 2 with weak central analgesics like the association paracetamol codeine. And if it doesn't work, we go to the level 3 with a strong central analgesic or opiate like morphine in subcutaneous way or Pyros. The noun of it is Moscantin, or by pump. We could do what we call analgesic radiotherapy if we have some bone metastasis, and for neurologic pains we give Laroxil. If we have a bronchial tumor that obstruct the lumen of central airways, we have to do what we call bronchial unblocking, and that it is possible thanks to the bronchoscopy, and we have to do mechanical debridement and endotracheal prosthesis. We could do it also by laser, cryotherapy, or endobronchial curetherapy. As you can see here, we have a tumor that obstructs a big part of the trachea. Here we can see it on the endoscopy, and if it's grow, the patient will suffocate. So we have to remove that tumor, and we put a prosthesis. It's a silicone prosthesis that allow the air to enter to our lungs. Here it's the same thing. It's a tumor that is near the carina, so we remove that tumor thanks to the bronchoscopy, and we put a prosthesis which has the form of Y. Yeah, the other methods that allow us to have symptomatic treatment. For example, for patient who has carcinomatous lymphangitis with a dyspnea, we could do corticosteroids or oxygen therapy. We have always to think about psychology of the patient by giving him some anxiolytic or antidepressants. The nutritional support is very important, and for recidivant recurrent pleural effusion, we could do what we call TALC. What about the prognosis of these tumors? Unfortunately, the prognosis is terrible, and it depends on the histological type and the stage of the tumor. But overall, we have just 10% of survival at 5 years. But thanks to the new therapeutic, things are changing. The lung cancer is a tumor that we can prevent by smoking prevention, a smoking cessation, and the improvement of working conditions. To conclude, lung cancer is a frequent and very deadly cancer. Late diagnosis because of the non-specific signs, clinical signs, and we have the diagnosis often at the metastasis stage. The main risk factor is smoking. The interest of the prevention by awareness campaigns against the harmful effect of tobacco. And we have not to forget about the professional context. We have always to think about it. So, what we have to keep in mind, it is the most common cancer in men, with the main risk factor smoking. We have non-specific clinical signs, but we have always to think about lung cancer for patients who is smoker, who has any lingering symptoms or loss of weight, so we have to explore it. We have unfortunately late diagnosis, with the chest CT scan as the key examination for the positive diagnosis and also for local, regional and remote extension. The histological diagnosis is possible by biopsies, by bronchoscopy or transthoracic or others, depending on the location. We have several histological types of different expressions and severity, and unfortunately, we have a poor prognosis.